Good evening and a very warm welcome to all the listeners who are joining us this evening for the webinar titled Lessons from the Field on a Community-Based Non-Communicable Disease Prevention Intervention in Punjab, India. We are here today to discuss a project that started a while ago as a partnership between the Harvard School of Public Health, its India Research Center, and the Ambuja Cement Foundation. And today's discussion, joining us are faculty from the Harvard T.H School of Public Health and the practitioners from the Ambuja Cement Foundation, as they will be sharing learnings and findings from a baseline study that was conducted for this NCD based intervention, and that has been recently published in the Indian Journal of Community Medicine. For everyone's reference, our team will shortly be posting out a link to this study. Working closely with the Bathinda Health Department within the Punjab Government, Ambuja Cement Foundation, with evaluation support from the Harvard School of Public Health, India Research Center, completed a study of the current scenario for non-communicable diseases in the selected villages. The published article describes the results of a large-scale community-based NCD screening conducted in Punjab using Government of India's community-based assessment checklist, the CBAC scoring system. The study is unique given that it is one of the first attempts to estimate the prevalence of high CBAC scores in a large population-based sample. Given that Government of India aims to undertake population-based screening for all adults on NCDs, the results of this particular study are directly translatable for policy action. In this webinar, we hope that panelists will be able to best and better highlight the findings of the study, what went with the intervention design, and what are the future lessons for public and private stakeholders on NCD management. So with that, a couple of words on the organizing partners for the webinar today, which is the first global center of the Harvard T.H School of Public Health. Established in 2015, the center has three strategic goals of research, teaching, and translation of evidence into policies and programs. The center is led by Professor Viswanath, who's the Lee Kum Kee Professor for Health Communication at Harvard University. And the webinar is being co-hosted by the Ambuja Cement Foundation, which is a grassroots pan-India implementing organization that harnesses the power of partnerships between communities, government, and other like-minded corporates and NGOs to really help solve pressing community problems, and also has a full-fledged research and monitoring unit to really monitor the impact of their work. So with the introduction of the partners, I'll also take another minute to introduce our esteemed panelists, starting with Professor Lindsay Jacks, who is the adjunct assistant professor for global health at the Harvard T.H School of Public Health, and now is at the Global Academy of Agriculture and Food Security at the University of Edinburgh. The overarching goal of Professor Jack's multidisciplinary research program is to advance our understanding of the complex interactions between agriculture and identifying effective programs and policies to transform the agro-food systems for holistic sustainability. Then we are joined by Professor Shilpa Pattaraju, who's the Assistant Professor for Nutrition at the Harvard T.H School of Public Health and the Harvard Medical School. Dr. Shilpa's research focuses on the dietary and lifestyle determinants of cardiometabolic diseases, and she has a special interest in studying the high-risk groups, such as the South Asians. Dr. Shilpa's work ranges from examining diabetes progression to developing a global diet quality index that helped capture the risk of undernutrition and chronic diseases amongst children. Thank you, Professor Lindsay and Professor Shilpa, for joining us today. Now going on to the practitioners who come with again years of experience from the field, we are very happy to be joined by Dr. Vinayak Sonavene, who's the head for the health vertical at the Ambuja Cement Foundation. Dr. Vinayak is the senior program manager who is overseeing all the health related projects across locations in 11 states of India. Dr. Vinayak specializes in maternal and child health, malnutrition, and adolescent healthcare. And he's worked in various capacities with various NGOs across the country. And we are happy to be joined by Ms. Shilpi Gupta, who has over 15 years of experience in project management and research and development. Ms. Shilpi is experienced in managing large-scale projects, trainings, summarizing research findings, and evaluating data and presenting results. And she's currently engaged with the ACF as a senior program research manager. And I am Dr. Ananya Avasti, the moderator for this session. I'm the Assistant Director for Research and Government Partnerships at the Harvard T.H India Research Center. So with that context and introductions, could I please request Professor Lindsay Jacks to give us an overview of the paper that we are talking about here, of the trial that we are talking about here, and how this entire project really started.
Thanks so much, Ananya. I'm going to go ahead and share my screen. Get this going. Apologies. Great. And just want to confirm, Ananya, are you able to see the my main slide deck?
Yeah, go ahead.
Excellent. Terrific. Well, thank you so much. It's great to be here and to share more information about this study, which was hard to believe started 3 years ago before the pandemic. So we're just so delighted to see it published and to share the findings today, and look forward to the discussion with the panelists and with the audience after a brief overview. So one of the reasons, just by way of background, the focus was on NCDs, which was quite unique at that time for these types of programs. But the reason that the focus was on that is that NCDs are amongst the top risk factors in India today. So here you can see the top risk factors in terms of mortality and morbidity in India, and the trend in these risk factors over the past 10 years. And you can see that for risk factors like malnutrition, there's been a substantial reduction in terms of the contribution of that risk factor to mortality and morbidity due to widespread programs that have been implemented in India and overall economic development. However, other risk factors, things like high blood pressure, high fasting blood sugar, and tobacco, have been increasing over time. And so these were really the major focus for this project. And in terms of how we went about measuring risk for NCDs, as Ananya mentioned, we use the community-based assessment checklist, which is a Government of India checklist to assess NCD risk factors that's being scaled up across India. And the CBAC check.
Sorry to interrupt, Lindsay. I think the slides are not visible. I mean, the slides are not changing in the. So.
Oh, okay. Which slide do you see now, Ananya? Sorry about that.
The cover slide.
Oh, okay. Maybe you're seeing my other screen. Let me just try this again.
Yeah.
Is it moving now?
Yeah, please go ahead.
Okay, great. So the CBAC checklist has 6 risk factors that are covered on that. Age, waist circumference, tobacco, alcohol, family history of NCDs, in particular, hypertension, diabetes, heart attack, and stroke. And then finally, physical activity. So after assessing these 6 risk factors, a score is assigned that ranges from 0, representing low risk of NCDs, all the way up to 10, which represents the highest risk of NCDs. And the government has recommended that any score that's above 4 should be considered a high-risk individual. So what we did was in Bathinda, across 10 villages, we assessed all of the adults living in those villages for these 6 risk factors. So that population sample size was around 11,300 adults. And it really was the first time that a community-based screening of CBAC had been conducted and published. So I'll talk a little bit more about what our findings were in terms of that high-risk score in just a minute. But before I do, I wanted to kind of show the breakdown of those risk factors that I mentioned contribute to the CBAC risk score between low risk and high risk individuals. And of course, you see significantly higher values for most of these risk factors in the high risk individuals. They're more likely to drink alcohol, to be a smoker, or use chewing tobacco. They have a higher prevalence of family history of all of the NCDs. But not a big difference in terms of low physical activity. So it was really the alcohol, tobacco, and family history that were contributing to pushing those individuals into the high risk category rather than the low physical activity. And I also want to point out the prevalence of tobacco use in particular. It was quite low here. And I'll come back to this at the end when I talk about some recommendations for CBAC scoring moving forward. But these levels are much lower than one would expect based on other surveys that have been done in Punjab and other CBAC scoring studies, which I'll mention on the next slide. So overall, once we scored everyone up, it was about 14% of adults who were classified as high risk, having a CBAC score above 4. And there was a wide range across the villages. So as I mentioned, there were 10 villages that were included in the study, and the prevalence of high risk CBAC score ranged from a low of 6% in one village all the way up to 31%, so about 1/3 of adults in another village. So there really is quite a bit of variability village to village in these scores, even within one district. So it does suggest that having microdata is quite important because one estimate is certainly not going to capture that level of heterogeneity. One interesting finding is that we didn't find a significant difference between men and women. They're equally likely to have high CBAC scores. And in general, and this was quite a surprising result, but it does reflect the larger epidemiological transition literature, but high-risk adults were actually more likely to have a lower education as compared to low-risk adults. So you're starting to see that high risk of NCDs actually affect lower socioeconomic status individuals. And this is even in a rural area, generally rural area in Punjab. So I think this really highlights the need to kind of emphasize NCD risk factors in addition to kind of traditional health risks like malnutrition and poorer and lower education populations in India. So in terms of comparison, as I mentioned, our study is the first population base that we've been able to find that's been published on CBAC scoring. But there have been 2 previous studies that did calculate CBAC scores in other populations, and I've summarized those in this table. But both of these they were conducted in the same year as our study, but they were both in health-seeking populations. So one was an outpatient department, another was a medical camp. So you might expect, given these are healthcare-seeking populations, that they would have a higher CBAC risk score. And indeed, we did find that their scores were nearly double what we found in this population-based sample in Punjab. In both of those studies also, I'll just note that the prevalence of tobacco use, alcohol use, and family history were all higher than what we found in our sample. So one thing to point out is that in addition to the CBAC scoring, we also measured hypertension from blood pressure measurements and diabetes from a finger prick and a point of care testing device. And what we found was that actually, even for individuals who the CBAC scoring technique classifies as low risk of NCDs, 1/5 of them actually had an NCD, had hypertension, and about 8% actually had diabetes. So the low risk classification of those individuals really would miss out on some individuals with NCDs. So I think that this has important implications when we think about using the CBAC scoring and kind of understanding who's going to get missed in terms of classifying as high risk and who may be missed in terms of connecting to healthcare to kind of address these risk factors. But of course, not surprisingly, overall, the high risk CBAC scores did have a higher prevalence of hypertension and diabetes. And just want to throw up for comparison here that our estimates of hypertension and diabetes are quite similar actually to NFHS5 data, with diabetes being just a little bit higher with that data set compared to our sample, but overall quite similar findings. So in just a couple of quick conclusions, this is the first population-based CBAC scoring. We found a prevalence of about 14% for high-risk CBAC scores. But there are quite a few considerations, I think, moving forward. The first is that the majority of the CBAC, the checklist items are actually self-reported. The only one that's not self-reported is waist circumference. And this is important to consider because there may be substantial underreporting of some of those risk factors, for example, tobacco and alcohol, which we suspect were underreported in our sample, as well as family history of disease, because you only know if your parents had these diseases if they were diagnosed. And so there may, because of low diagnosis rates, you may see a low reporting of family history. In addition, waist circumference in general is a bit of an invasive measurement, particularly if you do follow the gold standard approach for measuring waist circumference, which is to put the measuring tape on bare skin. And so one conclusion we have after this experience in Bathinda is that it should be considered, other measurements should be considered that are less invasive and maybe more accurate in terms of capturing individuals who are high risk of NCDs. In particular, blood pressure, which is a very low cost measurement, could really improve identification of adults who are at risk of developing NCDs like cardiovascular disease. So that's it for my brief overview, but look forward to answering questions as part of the discussion.
Thank you so much, Professor Jax, for a very succinct yet a very informative presentation, giving us all an overview of the paper and of the baseline trial. So feel free to post any questions that you may have in the Q&A box, and we can all come back to any specific questions that you may have. So with that, let us take a step back. We've all heard about the key takeaways from the baseline study, and we will talk about the intervention. Let us take a step back and ask you, Ms. Shilpi Gupta, could you really tell us more about what initially drove the ACF team, which is a leading CSR organization, to partner with academic researchers such as the Harvard School of Public Health, its their research center? And so how did it all happen, and what role did the center itself play in facilitating the partnership, and your own Mumbai team and Bathinda team? Give us some insights in that regard.
As you know, the Ambuja Cement Foundation is working in the ground for nearly 3 decades, and we work in different geographies in India. Health is one of the major programs which has been, grown over time, and we have added focus on MCH, NCDs, malnutrition, adolescent and child health, etc. So when we came to know that Harvard has a center that is opened up in India, and they are also working on health at different geographies, we were really glad, and we had an opportunity to collaborate and bring in more value to the work that we were doing in the field of health and NCDs. So we at Ambuja Cement Foundation, being the experts in implementing projects on the ground, and Harvard being experts in field action research, we thought of working together on a replicable model on NCD interventions in India. With respect to the role of IRC, that is actually, we had a very good experience with IRC, with the whole partnership that they have made it work, and it was really a great collaboration.
Thank you, Shilpi, for giving that context. Let me come back to you, Professor Jacks, because I see that a lot of people who are tuning in are really keen to know about how you use the CBAC checklist. So can you throw some more light in terms of your own experience with using a CBAC? There have been two questions already sort of highlighted. One being whether you can combine BP measurements with the CBAC scoring, and if you were able to identify a reason why the scores were pretty similar for men and women, and any other specific insights that you had on using the CBAC score.
Yep. So just a little bit more in terms of background, because I saw that there was a question about that. The sample for our study, the sample was a population-based sample, meaning that in these 10 villages in Bathinda, every adult, the field teams went house to house and interviewed every single adult that was there. So this is in contrast to the previous two studies that we were able to find in our literature review that actually just interviewed people who came to an outpatient clinic, for example. So it's quite a different sampling approach, and they answer kind of different questions. So when I mean by first population-based, it's really, as far as we're aware, the first published population-based survey that wasn't leveraging patients that were seeking care. In terms of how the score is actually calculated, for each of the 6 risk factors, a value is assigned based on the measurement that that individual has. So just take an example of physical activity. If an individual, we used IPAC, which is an international physical activity questionnaire, to measure the amount of work physical activity, leisure physical activity, and transport-related physical activity. And we calculate the number of minutes that an individual engages in terms of physical activity per week. And for the CBAC score, if you have less than 150 minutes of physical activity per week, you get a value of 1. If you have over that, you get a value of 0. And so, the risk factors kind of keep creeping up your score towards the maximum of 10. So if you smoke, if you use tobacco, it increases your score a bit more. So you just basically calculate it by going through the value for each of the 6 risk factors and summing them up. So it's quite a straightforward score to calculate. It doesn't include blood pressure, but it would be pretty straightforward just to tag blood pressure in, or to substitute blood pressure in for waist circumference. So not measuring waist circumference and instead measuring blood pressure. You could keep the maximum score at 10 and just use the blood pressure instead, though that's not currently within the recommendation. So just want to note that that's just something that we've proposed as potentially a way to pick up more of the high-risk individuals than the current scoring, but it's definitely not currently within the recommendations for the CBAC scoring technique. And apologies, the checklist is not filled out by the individual. The data is collected by an interviewer, and that's within the recommendations for CBAC. So when I say self-reported, I mean that the values, for tobacco, for example, the data collectors aren't directly observing tobacco use or looking for packets of chewing tobacco around. They just ask the participant, do you use tobacco? And it's self-reported back to the data collector. So apologies for the confusion about that. Yeah. Did I miss one of these? I'm sorry, Ananya, I'm kind of reading the questions as they come in, but what was the other one? I think there was another one that I've missed here. Oh, the male-female differences. Yeah, so there are kind of 2 things there. One is that, as I mentioned, so we certainly hypothesized going into this that men would have higher CBAC scores than women, particularly because alcohol and tobacco are 2 of the 6 risk factors. And we know that in general in India, tobacco and alcohol use are much more prevalent among men. I think one of the reasons why we didn't see a big difference in our sample is, as I mentioned, tobacco use was not very prevalent. We think it was underreported in this sample. So we only were seeing, say, 10% of people who were actually using tobacco, which is quite low. You might expect something much higher actually for men in Punjab, but we didn't see that in our sample. So I think that one of the major reasons we didn't see a difference was just the overall low reporting of tobacco and alcohol use in this sample. But one thing to point out is that we did look at not CBAC scores, but looking at hypertension, particularly just kind of blood pressure and diabetes, fasting blood sugar. And we did see some slight differences there. We also saw some differences in dietary intake, and I'm not sure if Dr. Shilpa will be talking a little bit about that and kind of a future question and as part of this panel and kind of the intervention that they're working on. But we did see more prevalent unhealthy diets among women, and so there's definitely some concern in terms of NCD risk for women that isn't really picked up by kind of general hypotheses around women being at lower risk because they don't use alcohol and tobacco. So I think it basically suggests that both women and men need these NCD prevention interventions.
Thanks, Lindsay. You made my job very easy in terms of catching all the relevant questions from the listeners. So again, I think, moving on to real world implications, I mean, to conduct such a study, to conduct it in a community-based setting, and to, at times, local support becomes a necessary and sufficient condition for conducting such trials. So in this regard, Dr. Vinayak, can you share, especially from the point of view of a CSR organization, which may be potentially interested in implementing such trials, just tell us more about how you foster key partnerships with the district administration, and how did they help you with data collection on the ground?
Thank you, Ananya. So basically, frankly speaking, we have very good rapport with the public health department in Bathinda. Rather for the different projects we have, across for over the period of time, and we worked on different projects into the community level. So that was a rapport basically was very helpful. Second was basically once the guideline was out for the CBAC assessment, and that was really helpful to create a model which is evidence-based. Basically replicable and affordable in terms of continuum care is concerned. So that was a thought how we can then make it sustained if we partner with the public health department, because that's a major key stakeholder. And when it comes to the NCD, so it's very important that the medicine stability is very important to when the diagnosis is confirmed. So the continuum care has been mentioned. So that is how we started discussion with the Bathinda Health Department, and then we put this as a part of the research study, and considering Harvard as one of the key partner, and we discussed this is how the model is going to be evaluated and replicated in coming time, looking at the findings. So that is how we thought to take this program ahead, and very positively the health department actually was agreed to provide the support on the screening part, providing medications and all that. And we as a ACF large foundation was a part of this project where we can create a behavior change interventions on the ground. So that is how this partnership was really helpful, especially when this guideline was issued. That time the maternal child health was still very much focused, and the NCD was not really been given a thought on the ground level. So that time the Punjab Health Department was basically very keen to support this program and come ahead, especially maybe looking at the prevalence, like Dr. Lindsay has mentioned, the high prevalence of diabetes and hypertension. So this partnership was basically like a very good which we started 2-3 years back. So it was very helpful from Health Department side to take this initiative ahead. Yeah.
Thank you so much. Since you mentioned the intervention, And it'll be interesting to now find out what happened after the baseline study was conducted. So I'd like to invite Dr. Shilpa to tell us about phase 2. How did that come about? What were some of the key learnings you picked up from the baseline data, and where is the study now, and how's the designing of the intervention and its implementation going on? So what does second phase look like for this project?
Thanks, Ananya. So after the baseline was conducted, the pandemic hit. So we did plan the intervention to take off right after the baseline. And based on that baseline findings, we wanted the intervention to focus on 3 main topics. The 3 approaches were improving overall diet quality. I think that was important given that diet quality was pretty low in this group, and you can see that, read that in the paper. And also lowering the prevalence of alcohol and tobacco use. Again, this was directly informed by the baseline findings. And importantly, leveraging ACF's experience on the field and the connections with the local health centers, we wanted to make sure that people who were diagnosed with hypertension and diabetes were in fact getting the treatment for it, because that was one of the major gaps that we found in our baseline report, is that people who were diagnosed from the blood pressure readings or the fasting blood glucose were in fact not getting the required treatment. So this was a holistic approach. We're looking at treatment, but also prevention through diet and lifestyle. So after, the field activities were shut down when the COVID, the wave hit, but when things settled down and the case numbers were low, we had regular calls with the staff in Punjab. And as soon as the case numbers became low, we started the intervention. The intervention is a stepwise intervention. So the first 6 months, the four set of villages received the intervention. And after that, we go back and collect data again on all the high-risk participants. And then in the next phase, the next set of 4 villages get the intervention, and that goes on for 6 months. And then we collect the data again. So right now we will be finishing the second step of the intervention. So a total of 8 villages will be completed. And then we'll launch the last phase after in May. And 6 months from then, we'll be collecting data on all the high risk, and we'll be analyzing the data at that point.
Thank you. Thank you so much. Since we have, we'll shortly dive deeper into the intervention design itself. But before we do that, Professor Jacks, you did the baseline study, and findings are, of course, for all of us to read. But what, in your understanding, are some of the key findings that can potentially have far-reaching policy implications for the government, especially in light of the NCD focus that Government of India's Ayushman Bharat program has?
Yeah, so I mean, I think one of the key findings was that I think really has important implications for potential updates to the way that population-based NCD screening happens, is the observation that quite a sizable proportion of people who the CBAC scoring classified as low risk for NCDs actually had diabetes or hypertension. And so I think it basically means, particularly for hypertension, because as I said, about a fifth of the low risk people, like CBAC low risk people, had hypertension. So that's a big number of people. I think that adding more regular population-based screening using blood pressure monitoring would be quite valuable. And I think that is, starting to happen in a lot of places. I know in Andhra Pradesh, for example, that type of screening is happening. But, we've talked about this before, but it's one thing to kind of make the measurements available so that people can be screened. But there's also kind of this behavior around screening for NCDs, particularly as the prevalence of diabetes and hypertension is going up, and these are becoming very common disorders all over India in rural and in urban settings. You're finding a lot of people who just don't want to know that they have it, perhaps, or not very motivated to go get testing for various reasons. And so I think there also needs to be quite a bit of work, not only on increasing access to these types of screening, but also kind of increasing understanding of what these diseases are, how they're very treatable, very manageable, even with lifestyle changes, and kind of encouraging people to find out whether or not they have high blood pressure or high blood glucose, and kind of engage in lifestyle changes that can kind of reduce their risk of complications. So I think there are kind of two bits to this. There's kind of the screening and the recommendations for trying to identify people within the population who have these, but also trying to kind of increase awareness of the fact that these are manageable diseases. And I think that's really what the next stage of after the baseline, that's really the next stage of this program is kind of demonstrating that these things are treatable and manageable.
Yep. Then moving on to the next stage, Dr. Vinayak, why don't you start with telling us about how ACF has been thinking about the NCD intervention, where you really see it going, and how are you also planning to translate these findings to other geographies that ACF works on within the country?
So yes, basically we try and see which are the models which we can directly start implementing into the community, which create a larger impact. And over the years, we have intervened remote and rural geographies, which is definitely has a larger challenging programs like maternal child health, where we had a crisis of infant mortality and neonatal mortality. So these are the programs which we have intervened and taking the learnings from the programs. And now we are also expanding with the larger segment of the population with the lifestyle diseases, looking at the high prevalence of NCD interventions. So our approach also is remaining preventive and promotive healthcare, focusing from the curative healthcare services. And our thought was how this study can help us to the of course general awareness is major part, but how we can transform this at an individual level with the lifestyle modification. And that is how we started this interventions planning for this program. So major I can say takeaways from this project is like a volunteers who actually was taking a monthly session with the population, and that was basically was focusing on nutrition counseling. And we also have created a behavior change health card, which basically was having a simple modifiable indicators listed on that, and the individual can definitely check the progress, how is modifying the indicators over the period of time. So this volunteer was really helping them to modify these indicators or take a behavior change accordingly. So that was very helpful. Second, I'll say the IC material, which is definitely as a part of the baseline study, we can see that the consumption of fruits, pulses, and nuts was really low, and the high on salt and sugar. So that basically was a learning, and we thought maybe we can create a customized IC material which will focus on very key messages to the beneficiaries. And we have created these charts of vegetables, sugar, salt, carbohydrate, how we can replace the trans fats or the saturated fats. So that is how this IC was been provided, used for the counseling session, and that was taken to the household level. Another, I will say, key holistic development. That is something which ACF actually focuses, very largely, and we taking another help from other thematics where we have inclusion of farmers, where we see that how can vegetable consumption can be increased to the kitchen garden promotion. So that we have started at every household level. Second, how we can make available of low glycemic flour supply to the SHG self-help groups. So that also we have ensured that the SHG groups are supplying that availability of the flour is also available. So this is how actually we are taking this a few learnings, definitely using this framework. And now we started expansion this program, in more than 200 villages, reaching out to 1.25 lakhs of direct beneficiaries. And I will say this study also has helped relatively because Harvard and the government is also there. So to take the partnership with the government in the other state, that also was really in that way. So this is really a good learnings we are trying and taking to the other locations effectively and reach out to larger population. Yeah.
Thank you so much, Dr. Vinayak, for giving the audience a sense of the scope of the impact of this study, and of course your other trials and projects in different geographies. Um, Dr. Shilpa, I think the audience would like to know greater details about, how you've been thinking about the intervention itself, as far as its designing was concerned, or also in terms of some other implications that you can so far identify that would apply to governments, which are sort of mandated to work in the area of NCD prevention, and of course other development partners.
Yeah, so I think in terms of the intervention, one of the key areas we wanted to focus on was diet, because diet is such a central factor for not only prevention of chronic diseases, but also for treatment. And the baseline report highlighted, several gaps where the diets could be improved. So we, leverage the data, the evidence that we developed at the Harvard Chan School of Public Health and the Department of Nutrition. For example, we have the My Healthy Eating Plate, which reflects, shows a very clear pictogram as to how a plate should look. So we developed that and translated it to My Healthy Thali. And that was translated into the local language and distributed to everyone. So that was very helpful. And then, as Dr. Vinayak was talking about, there was the behavioral change card, or the BCC card. So this was a way for the participants to keep a track of the behavioral changes. And every kitchen, every household had a pamphlet of the My Thali in the kitchen. So they knew exactly how they should be consuming. The proportions that they should be consuming in terms of pulses, which was very low, consuming more whole grains, lowering salt, lowering added sugar. That was a huge intervention source that we thought we could make. And your other question was how can governments actually take this? I think including diet in the CBAC score is also very important in addition to hypertension. We recently developed a global diet quality index, which can capture both the risk of undernutrition and overnutrition or chronic conditions. And this was tested out all over the world. And so I think including that with the CBAC scoring is critical, because diet is one of the major risk factors for chronic disease prevention and treatment.
Thank you. Lindsay, would you also like to come in on the importance of diets? I know a lot of your work is around the same. So would you like to add to what Dr. Shilpa just flagged our attention to?
Yeah, no, I was just going to say that I fully agree with what Dr. Shilpa just mentioned about including something like the DQQ. And I'll put the link into the chat for the Indian version of that questionnaire, but it's a really simple, 2-minute questionnaire that not only captures NCD risk, but also would capture risk for undernourishment, things like anemia and underweight. So I think that would be a fantastic addition to this kind of screening, just because it's so quick and very, very informative. And it relates to another question that was in the chat about kind of what's going on in these areas. NCDs are going up, but what's going on the other end of the malnutrition spectrum? And I just wanted to point out that in response to that, I did mention that unfortunately the NFHS5 data suggests that in Bathinda, both anemia and slightly underweight are actually going up over time as compared to the previous round of NFHS in that district. And so you're seeing an increase in NCDs at the same time that you're seeing these kind of unaddressed issues of undernourishment still kind of existing and in fact going up a bit. And so diet is really, unhealthy diets are really the thing that is linking those trends together. So adding the DQQ would be fantastic, particularly because it's already been implemented in India and validated there and in other countries. So I think it would be a great addition.
Thank you. Thank you so much, Lindsay. Again, taking a step back, coming to Shilpi, in terms of just implementing not just the trial, you've been also supervising the field teams as far as really taking the intervention to the communities is concerned. And so much of it is to do with SBCC, and it's a very patient work to do on the field. So what are your experiences like as far as interactions with communities go?
Yeah, sure. So this being an action research project, we were expected to manage both the different level of data collection in the field and implementation of planned interventions on the ground. Even though we had a direct involvement of professors from Harvard in data collection, our teams on the ground had to manage smooth data collection and do the interventions. COVID had hit, and that, as Dr. Shilpa has also mentioned, there were a lot of challenges we had faced because of COVID. And one is that we could not complete the data collection, the baseline data collection for all the 12 villages because there was a nationwide lockdown which was put, and then we had to go ahead with the analysis of 10 villages for the data collection. Then the interventions were supposed to start soon after the baseline, but we had to wait for a few months before we could start. Our planned interventions included a lot of group meetings in the community and doing some sessions like yoga sessions, etc., which were not allowed because of the restrictions of COVID. Then counseling of the high-risk individuals had to be done telephonically. And another challenge was that since this was a long-term study and extended a lot due to COVID, we could not retain the same set of investigators. Those were trained by the professors at Harvard. And then for the midline data collection, the second round of data collection, we had to hire the new set of investigators and train them again, and then getting the data collection done. So it required a lot of efforts from the field, though we managed well. Another challenge that we had faced was with the IEC material, because a lot of material was available, but it was in English. And we were expected to create all those material translated into the local language in Punjabi. And we had to do a lot of back and forth with the Harvard team to get it translated and then put it in field. I would like to say that one big strength of this project about our intervention was that our volunteers, they met every high-risk individual personally and made them aware about the risk factors and the better choices that are available for them. And like Dr. Vinayak said, we also introduced a BCC card for them to keep track of their behavior over the time. So overall experience was really great.
Thank you. Dr. Shilpa, could you tell the listeners more about, you mentioned the healthy eating plate, where Harvard Chan faculty have done some phenomenal work around it. And with the soon to be released ICMR and IN guidelines on recommendations for Indian diets, it all makes sense. So can you tell us more about what is really a healthy eating plate?
Sure. So the Harvard Healthy Eating Plate is an adaptation of the Healthy Eating Plate that was put out by the USDA. It is really an adaptation by including more evidence-based science and literature. So the pictorial is a plate, and then the goal is half of your plate should be of fruits and vegetables. So that's an easy message for someone that consumes food to know that half of your plate should be filled with fruits and vegetables. And then the other half should be filled with whole grains. A quarter of it should be filled with whole grains and the remaining with healthy protein. So when we talk about healthy protein, we're talking about, nuts, legumes, and primarily plant protein, and I think that's important from a sustainability standpoint as well. And you know, the dietary guidelines don't take into account sustainability, but we do know that sustainability and health are so closely interlinked. So when we talk about healthy protein, it's mainly plant protein, and accounting for some amount of poultry and fish, but limiting red and processed meat, and then including healthy oils. I think that's important because we need to move away from the low fat diet era where, you know, the idea is we want to limit fats. It's the idea we need to move away from limiting fats to focusing on the quality more than the quantity. So fats are good for you, but eating the right kind is important. And this is especially of significance in India, where there's a lot of trans fat consumption. So a lot of our intervention materials focused on lowering trans fats and where trans fats are hidden. You know, things like samosas, baked goods, and biscuits that aren't really visible to people. And then the healthy eating plate also focuses on consuming water, you know, being well hydrated. So that's, we took principles of the healthy eating plate and included that in our intervention.
Thank you. And Vinayak, if you could throw some light on how the communities took to it, like how challenging was it to introduce a tool like this, and just what are some of the learnings for those of us who are in the public health space to learn from?
So when we introduced this BCC card, frankly speaking, it's not only the individual who actually was, following the lifestyle modification with the indicators. It's the entire family was, attached to that. If you have to cut down on the sugar, so definitely it's not only for that person. Gradually the low sugar, tea will be, served for the family. So that was really creating an impact at a larger level with the family level, and that is how we learn. But what was important, because every every IC was which created, like vegetables, the sugar, everyone has a very specific message which was going to the beneficiary. Okay, how much of sugar is really can consume in a day, so that nobody knows how much salt can be limited in a day. So that specific message was going to each family, and we pasted all these IC at a household level. So that was like good benefit, because that ICs remains to next to him for next 6 months. So that was really helpful for the community, the family, and the individual, and see the changes happening in his own BCC card. And that was really helpful. And we also tried and connected with the nutritionist over the phone at least once. So whatever doubt he has, he was able to get back to the nutritionist, address that. So frankly speaking, when we had a visit to the few villages, the household, that was really amazing, change we can see. People have formed walk groups, which was, so in the groups, they're going for a walk in the morning. Open gyms actually started using by the families or the groups. So these are few good learnings, it's just a start, and, and the individual, family, and the community start, developing on that. So I think that was a very good learning over the period. Yes.
Thank you so much. And these are really very interesting learnings. Lindsay, one final question to you in terms of wasn't the case when the baseline data collection for this study was done. So how has that changed the learnings that this sort of study had for you as an academic researcher, and what does it really where do you think, which direction are we going as far as India's nutritional profile?
I think my internet cut at the very beginning. Were you saying COVID wasn't there when baseline happened?
No, I mentioned NFHS 5. I mentioned NFHS 5 data wasn't there.
Yeah.
So,
yeah. Oh yeah. So yeah, I mean, the big takeaways from NFHS 5, unfortunately, were, well, first off, NCDs are a big problem, including in rural areas, with diabetes rates of upwards of 20%, which is higher than in the US in some states in rural areas. So diabetes is a huge problem, and as I showed on that first slide, the contribution of diabetes to mortality and morbidity in India has increased by 61% over the past 10 years. It's the biggest increase of any of the risk factors that IHME tracks. So I think diabetes is a huge concern, and it relates to the lack of diversity in diets, for example, that Dr. Shilpa mentioned, that, still in India to this day, over 70% of calories are coming from a single food group, whether it be wheat in North India or rice in South India. We really need more diversity in diets. The other key takeaway was that we haven't really made a dent in terms of undernourishment. Things like anemia is still quite high. We're not seeing that really strong downward trend that we'd like to see. And again, it goes back to the lack of diverse diets, I think. You won't fix anemia just by having IFA supplements, or even not just IFA plus fortification. You've got to have the diverse diets along with it. So I think that the current approach by WCD and Ministry of Health and other stakeholders to kind of have a multi-pronged approach and kind of recognizing the multifaceted nature of anemia is great. And I think that really implementing that, and not just having the IFA tabs, but also the fortification, also the emphasis on diversifying cropping systems and diversifying diets will really be key. You need all of these things together in order to really move the needle on anemia, and there'll be benefits for NCDs as well, which is great.
Thank you, Lindsay. And maybe one other final question to you, Dr. Shilpa, that's just been put on the chat. I think you already typed it out, but if you'd like to just,
Sure. Yeah. So we, made this intervention culturally acceptable. So, the recommendations were based on foods that people were already consuming. For example, one of the IEC materials is on added sugar. So thinking about how added sugar is consumed in this group, it's mostly consumed as part of tea, right? So targeting that and telling people to cut down on the amount of sugar. The other thing is switching to whole wheat is instead of refined flours. So that's another thing. And then potatoes is something that's widely consumed in this group. And potatoes are not considered a vegetable in the healthy eating plate. So telling people to consume more greens, talking about diversity that Dr. Jax was talking about, bringing more, color onto your plate in terms of the fruits and vegetables you're consuming, cutting down on foods eaten away from home, because that is a big source of trans fats. So these were all, the intervention was completely on locally available foods. Nothing new was introduced.
Thank you so much. So any final thoughts, maybe summarize just in a line the key takeaway that each one of us have had with this study, with implementing the intervention, maybe starting with you, Lindsay, and then moving on to Shilpi and Vinayak, and then concluding with Dr. Shilpa.
I actually had a final thought or question for the ACF team, and that was, based on the Bathinda experiences and kind of the findings, are there plans? I know that you're working in 11 states, all over India. Are there plans to do more of this NCD work outside of Bathinda?
Yeah, Dr. Vinayak has already mentioned it, that we are already working in more than 200 villages on NCD, and we are definitely going to take this model that we will be creating from this study to other locations, other areas where we will be working on. We have already started putting our learnings from this project, because we are intervening for about more than 12 months in different set of villages. We have started putting our learnings in different villages, and we have already started replicating things.
Sure. I think what's important, CBAC actually helped to identify the population. It's a pre-NCD population, and the population is actually into a diabetes and hypertension. So how we can do a behavior change amongst the pre-NCD population that will definitely restrict the NCD future NCDs, and how we can link the existing population with the diagnosis and treatment. So that is a major focus for us, and we taking that thought, working with the committees. Yes.
Dr. Shilpa, final word.
I'd just like to give a huge shout out to the folks on the ground. It's, something of this scale cannot happen without the volunteers who so patiently go from house to house, collect data, attend the trainings. So I think they are the real soldiers and the heroes of this project. So I think I'd want to really acknowledge them. And it's because of them that this has been so successful.
Thank you so much. Thank you all the panelists and the attendees. A special thanks to Professor Vish Viswanath, the director for the Harvard Chan India Research Center, who sort of oversaw the entire, partnership between ACF and Harvard. And at ACF, a special thanks to Pearl, to Anaga, and to Sanjay ji on the field, who sort of made this happen. A recording of this webinar will be available on our website, and of course the link to the paper has been shared, and we'll come back to you with the phase 2 of this webinar once the intervention findings are here to share. Thank you so much, and have a good evening and a good morning based on wherever you're joining us from. Thank you so much.